Hey, BC here for BCNephro. I'm a board-certified nephrologist and clinical specialist in hypertension in practice for more than 20 years. Today's topic, MGRS, Monoclonal Gammopathy of Renal Significance. For more information, check out the videos at this channel and the articles at BCNephro.com. A link will be in the description below. Let's get into it. So monoclonal gammopathy of renal significance, I'm going to talk about what it is, when to screen for it as part of evaluation for renal disorders, how to interpret that evaluation, and how to distinguish when the monoclonal gammopathy is truly the cause of the kidney disease, the kidney disorder. First, what is monoclonal gammopathy of renal significance? It is well known that multiple myeloma and certain B-cell lymphoproliferative disorders produce monoclonal proteins, and the monoclonal proteins in context of these disorders can cause a wide range of kidney disorders, kidney diseases, including light chain cast nephropathy, interstitial nephritis, and a number of glomerular disorders, including amyloidosis, C3 nephropathy, proliferative glomerulonephritis, and others, among others. There are many situations where there is a monoclonal protein in the blood and or the urine, which does not meet criteria for multiple myeloma, and there is not evidence of a B-cell lymphoproliferative disorder. In these situations, it's referred to as MGUS, monoclonal gammopathy of undetermined significance. However, the monoclonal proteins, even in these situations, can cause the same types of kidney disease, even in the absence of overt myeloma or a B-cell disorder. When this is the case, it's referred to as a monoclonal gammopathy of renal significance. Next, what patients, what type of kidney disorders should be screened for a monoclonal gammopathy as a potential cause? In my practice, I believe that most patients with different types of kidney diseases, if there is an unexplained etiology, should be screened for this. This includes acute kidney injury, chronic kidney disease with proteinuria or with a bland urinalysis, and when there's significant proteinuria of overt range, or specifically more severe proteinuria. How do I screen? Typically, as part of my initial evaluation is a serum free light chain ratio, as well as a urinalysis and both the urine albumin and urine protein creatinine ratio. The next thing is how I interpret these results. The dilemma is that monoclonal gammopathy of undetermined significance, MGUS, and chronic kidney disease are both fairly prevalent conditions, especially as the age increases with the aging population. And it is often the case that patients may have both of these disorders as unrelated, as opposed to the monoclonal gammopathy causing the kidney disease. I'm going to go through the approach how I try to sort this out. First, looking at the serum free light chain. Now, the serum free light chains are normally filtered by the glomerulus and then reabsorbed by the proximal tubule. When the GFR decreases, the filtering of both the free light chains, the kappa and the lambda, will both increase. So an increase of the kappa and the lambda is not suggestive or diagnostic. This can happen with the decrease in GFR. What we're looking for is the ratio, that one is increased more than the other. There's an elevated kappa to lambda or lambda to kappa ratio. Now, it turns out that the kappa light chain is more susceptible to glomerular filtration than the lambda, so the normal ratio with a decreased GFR is a bit higher. A normal ratio is up to 1.65. Patients with a decreased GFR typically have a mild increased ratio of 2 to 3. So a ratio would have to be above 3 or maybe even above 5 to be clinically significant in a patient with a decreased GFR. What I'm also looking for, in addition to abnormalities on urinalysis, is a discrepancy in the urine albumin to urine protein creatinine ratio. In glomerular disorders, the majority of protein is albumin, about 55 to 60%. So I'm looking for the albumin to creatinine ratio and comparing what percent of that is urine protein creatinine ratio. So if the urine albumin to urine protein creatinine ratio is much lower, less than 40%, that may suggest that there is overflow proteinuria, light chains in the urine, and this would increase my clinical suspicion. In these cases, my next step is often to do an SPEP and UPEP, as well as a serum and urine immunofixation to see if there is a large spike monoclonal protein that would be suggestive of myeloma. If there is, a step could be to send the patient to a hematologist for evaluation, which may include a bone marrow biopsy. I will tell you, in my experience, the majority of patients that have this and have a bone marrow biopsy don't meet biopsy criteria for active myeloma. So they may have less than 10%, that is 5 to 10% monoclonal plasma cells in the bone marrow biopsy, which is indicative of an MGUS, or greater than 10% without other evidence of myeloma, which is consistent with smoldering myeloma. And in these cases, treatment from a hematologic perspective is not necessarily indicated, and we need to still figure out if the monoclonal gammopathy is the cause of kidney disease. Now, the main way to figure this out is to do a kidney biopsy. So we need to sort out what patients should proceed with a kidney biopsy and what patients maybe do not need a kidney biopsy. This has been studied, and I'll link this study in the description below to look at factors that are predictive of the monoclonal gammopathy as the cause of the kidney disease. So in this study, patients with a monoclonal gammopathy who had a kidney biopsy, about 40% of those patients had the monoclonal gammopathy as cause of the kidney disease on the biopsy. 60% did not, had another kidney disease, most commonly hypertension, arteriosclerosis, and diabetic nephropathy. The predictive factors for an abnormal monoclonal protein causing the kidney disease were the following: an abnormal serum free light chain ratio, and the average ratio was above 5, and the majority of the patients had a ratio above 3. In addition, if there was an abnormal bone marrow biopsy, this increased the risk if there was an abnormal clone plasma cells. The next was the degree of proteinuria, and their best cutoff was a 24-hour urine protein of greater than 1.5 grams a day. The third thing was the presence of hematuria on urinalysis. These were all predictive factors. A negative predictive factor was the presence of diabetes. Only 20% of the patients with diabetes were found to have a monoclonal protein as the cause of their kidney disease, as opposed to diabetic nephropathy, diabetic kidney disease. And the patients with the monoclonal protein had more severe proteinuria. And the other thing to look for is a low C3. So these things would either increase or decrease the likelihood of finding a abnormal kidney biopsy that would then warrant treatment. Now, my personal approach is the following. I do have a relatively low threshold for biopsy if those above criteria are present. I'm also more likely to do a biopsy if there is a relatively rapid progression of the decrease in GFR, typically more than 5 mLs per minute per year, and if the patient is younger, more likely to pursue a kidney biopsy in that situation. So that's it, that's my approach. Please share this video with someone who you think might benefit from this information. And if you made it this far, you might as well hit the like button, subscribe. It helps me get this message to more people. And until next time, thanks for watching.